So the similarities between arteries and veins. Arteries and veins are all going to have three different layers. Tunica externa, which is also referred to as the tunica adventitia. So if you hear that term, they're kind of synonymous with each other. They're also going to have a tunica media. That's where you're going to find smooth muscles. And then there's going to be the tunica intima as well. Now, what are the biggest differences between veins and arteries? It's going to be one of these layers. Do you guys know off the top of your head? What's the major layer that differentiates arteries versus veins? Huh? The size of the lumen? Yeah, for sure. The lumen on veins, within veins, are going to be a little bit wider versus arteries. But I'm talking about regarding one of these layers. Which layer is going to be significantly larger in arteries compared to veins? The middle layer, yeah. So tunica media in arteries is going to be significantly larger than the tunica media within veins. In arteries are going to be pretty heavily responsible for controlling blood pressure and blood flow. So in other words, arteries are the main vessels that vasoconstrict and vasodilate. And so when vessels vasoconstrict, that's going to be involuntary stimulation of the smooth muscles that are found within the tunica media. And when they vasodilate, that just means that those smooth muscles are basically relaxing, allowing for a greater amount of blood flow through that vessel. So here's just a summary of all that. Just keep in mind that the tunica media, the smooth muscle layer, that's all going to be involuntary. So we don't really have any control over whether or not our vessels are dilating versus constricting. It's not working. There we go. Cool. So we already talked about this last week. We also covered quite a bit as to the other major difference, which within the tunica intima of veins, you're going to have unidirectional valves, right? So blood otherwise would pool in your lower extremities due to gravity. But with those valves, you're able to continually maintain the unidirectional flow of blood. However, those valves can indeed fail, and if they fail, that's when you get things like varicosities. You can also get telangiectasia. Telangiectasia basically is just going to be damage of those smaller vessels, but when it comes to varicosities, that's mostly going to be involving the valvular system. And then we closed last week. I showed you guys that sclerotherapy video, which is kind of cool. By the way, did anybody in here follow Medical Talks on Instagram? You did? Only one person? Come on, you guys got to follow Medical Talks because they're awesome. There's so much really like brutal stuff that's on there. What did you think? Did you like it? The thumb. How the hell did the guy slice his thumb in half? A guy was opening a glass bottle. The glass bottle broke, and he like cut his entire thumb like directly in half. So yeah, I don't even know if you could do that if you tried. It's like crazy. But there's a lot of really great videos on there that you should definitely check out. Videos and pictures. Risk factors for varicosities. Age is going to be a huge factor. So age, the older you get, the more stress that you've been placing on those valves over time. And over time, those valves may fail. Women are actually going to have a higher propensity for getting varicosities, especially during pregnancy. So you have like a larger amount of blood volume in your body due to pregnancy. Because of that, you might have a higher risk of getting varicose veins as a consequence. And then this last one's kind of funny. Standing or sitting. It's like, which one is it? So I guess sitting for too long or standing for prolonged periods of time, either of those can result in varicose veins over time. Let's talk a little bit about piles, also known more commonly as hemorrhoids. Hemorrhoids are effectively going to be enlargement and pooling of blood in the vessels that supply blood to the rectal region. And so there's two major types. There's going to be internal hemorrhoids and there's going to be external hemorrhoids. Internal hemorrhoids, generally not much of a problem. Patients that have internal hemorrhoids, they're usually not going to experience much pain. One of the most common symptoms for internal hemorrhoids is going to be bleeding. So it's going to be painless bleeding on defecation. External hemorrhoids, however, are going to be the ones that are more problematic. Those are the ones that the patient is probably going to go, seek out therapy of some sort. Generally speaking, external hemorrhoids can be treated just by using home remedies, things like Epsom salt baths, high fiber diet is another thing, wet wipes. Those are all going to be things that can help to reduce external hemorrhoids. But if it gets really severe, sometimes those might require some form of like surgical intervention. So that's what an external hemorrhoid looks like. And then these are some of the main causes. So straining during bowel movements. That's going to be one of the major causes of hemorrhoids. And obesity is also going to be a risk factor. And then again, pregnancy, just because of that, you have a lot more blood volume when you're pregnant. So let's talk a little bit about hemodynamics. I like that video a lot. It's kind of funny. I was trying to find out where that video came from, but I don't know. Anyways, so hemodynamics, that's basically the way in which blood is going to flow throughout your body. It's going to be determined by a multitude of different factors, like viscosity of your blood, aka the thickness of the blood pressure, also the radius of the vessels, which would contribute to the resistance of the vessels. So let's talk about the difference between blood flow versus perfusion versus hemodynamics. So blood flow is just going to be the rate of blood. It's going to be milliliters per minute. Perfusion is a little bit different. Perfusion is going to be rate in milliliters per minute, but it's going to be over a region, a given organ system, for instance. That's when we talk about perfusion of blood in, I don't know, let's say like in the brain, or perfusion of blood in the renal system. You can also test for peripheral vascular perfusion whenever you guys see your patients. If you squeeze on their nail beds and then you wait and see how quick it goes from being white, which means that you removed all the blood and then let go, versus when you get blood going back in. So you see the nail beds turning pink again. If it's super delayed, the patient might have some sort of like peripheral vascular disease. So that's going to be one example of how you can test for perfusion. Now, hemodynamics is going to encompass a lot of different factors. We're going to measure hemodynamics in terms of flow. And flow is just effectively the velocity of the blood going through a vessel. So that's going to be marked as F. And then the other factors that come into play are going to be the changes in pressure, so the delta P. So if you have, blood is going to move from high pressure to low pressure. The greater that pressure gradient is, if you start off at a really high pressure and go all the way towards a low pressure, that's going to increase the flow. The flow is going to take place a little bit more rapidly. And then that's going to be inversely proportional to resistance. So if you increase, for instance, peripheral vascular resistance or total peripheral resistance, say, for instance, vasoconstriction. If you increase the pressure, that's going to decrease the amount of flow. That means that the heart is basically going to be pumping up against a high amount of pressure, so you're going to get reduced flow in those regions. This is, we kind of already talked about this last week, but it bears repeating. The different areas in your body where you'll find blood being distributed. So keep in mind that a lot of your blood is actually found within your venous system. In general, the blood pressure in the venous system is going to be a lot lower than it is in the arterial system. And that's basically just a consequence of distance from the heart. The further you get away from the heart, the lower the pressure is going to be in those areas. So in other words, the aorta, which is going to be the first exit point into the peripheral vascular system, the aorta is going to have the highest amount of pressure. The superior and inferior vena cava, on the other hand, are going to have the lowest amount of pressure. But because of that low amount of pressure in the venous system, blood tends to pool in those areas. And that's why you need to have those valves in those vessels. So those valves can help to push blood back towards the heart. So let's talk a little bit about this equation here, measuring flow. So F is going to be directly proportional to the changes in pressure. So if you have a really high change in pressure, or a delta P, that's going to increase blood flow. On the other hand, if you have a lot of resistance, for instance, if you have like increased vasoconstriction, that's going to increase the resistance. And so the flow is going to have to move against a greater pressure gradient, and that's going to be reducing flow. Vascular resistance can effectively be likened to afterload. Remember, you have two different factors for when we're measuring heart cardiac output. You have preload and then you have afterload. Preload is the amount of venous return that you have coming back to your heart, right? So that's when you have the end diastolic volume, where you have a lot of blood filling into the chambers of your heart. And then after your heart contracts, it's going to be pushing up against the peripheral resistance. So if you increase vascular resistance, that can be associated with increased afterload. You can think of those as being synonymous with each other. So these are all the factors that are going to affect blood flow. Diameter of the vessels, that's going to affect blood flow. The more narrow the diameter of the vessel, the slower the blood is going to flow through that vessel. The wider the vessel, the faster or the more flow you're going to get through that vessel. I like this chart a lot because it shows the difference between the different vessels in terms of their radius / diameter, but also gives you an idea of the total surface area of all of those vessels combined throughout the entire body. The arteries and the veins are going to make up a small percent of surface area in vessels. As you get down to the capillary beds make up a huge amount of surface area when it comes to your vascular system. And then blood pressure. This is another thing that's going to come into play here. The closer you are to the heart in terms of output, like the aorta, for instance, the greater the amount of blood pressure in those vessels. As you move further along towards past the capillary beds into the veins and then up into the vena cava, blood pressure is going to be greatly reduced. And so all of those three factors are going to play into the total velocity of blood. So here's your circulatory pressure. Generally speaking, the overall delta P in terms of like pressure change throughout the entire circulatory system is going to be on average about 100 millimeters of mercury. So up here in the aorta, think of the pressure being roughly 100 millimeters of mercury. All the way when you get down to the vena cava, you're almost getting down towards a pressure of 0. Other things that are going to come into play. So blood volume is going to come into play with the total amount of resistance. And another thing that's going to come into play is viscosity. So the more viscous the blood is, the more thicker the blood is, the more resistance you're going to have. So for instance, if a patient had like polycythemia, where they had an increased production of red blood cells, that's going to increase the viscosity of the blood. And that's going to increase the amount of total resistance in those vessels. What's something else that might cause increased viscosity? We're going to get into that in a little bit, but what are other things that might contribute to viscosity of blood? Say, oh yeah. Huh? Anemia? Yeah, anemia could definitely contribute to changes in viscosity. Also, just fluids. So if you were, for instance, if you're on your date tonight celebrating Valentine's and you drank a lot of wine or a lot of whatever, favorite drink of choice, and then you got really dehydrated because alcohol is going to be a diuretic. And so you're going to actually diurese, so you're going to lose a lot of water volume. If you lose a lot of water volume, that can actually increase the viscosity of your blood, which is one of the reasons why you can get a headache from drinking too much if you get dehydrated. There's other reasons too, like, yeah, we're not going to get into that. But if you have a low fluid volume in general, you're going to increase that hematocrit, because remember, the plasma is mostly made up of water. And so the less water you have, the more red blood cells you have, the higher the hematocrit, the greater the viscosity, and then the greater the total peripheral resistance. What's up? Yeah, thickness. Think about like honey, right? Honey is really like thick. It runs slow, right? Molasses. Anything that's thick is going to run a little, it's going to have a higher resistance in its movement. So that's viscosity. Vascular resistance. So the reason why I have this image here of a little plaque, an arthrosclerotic plaque, is because resistance can be caused by narrowing of vessels. Let's let's actually look at this image over here. This is a really good image because right here you'll see laminar flow. When we use the term laminar flow, that just means you have flow of blood through a vessel that is patent. It doesn't have any sort of anomalies or constrictions that might result in turbulence. And with laminar flow, when you get into the middle of the vessel, that's where you have the greatest amount of flow because you have the least amount of resistance. The closer you get towards the sides of the vessel, the lumen of the vessel, the higher the resistance is going to be within that vessel. And so if you have a constriction due to arthrosclerosis, that's going to impact your laminar flow. And so it's going to increase overall resistance. Something else that can increase resistance is going to be distance. So the length of the vessel, the greater the length of the vessel, the more resistance you're going to experience within that vessel. Now, as a rule of thumb, we don't really have the capability of changing the lengths of our vessel. So for within the system, within your body, the vessel is going to remain constant in terms of length. The only thing that's really going to change is going to be the diameter of the vessel, whether or not you vasoconstrict or vasodilate. So if you were to be able to change the length of the vessel, the shorter the vessel, the less the amount of resistance. The greater the length of the vessel, the greater the amount of resistance. But in terms of what you can adjust, that's going to be the actual radius. And that's what changes due to smooth muscle contraction in your arteries. And then in terms of the way you calculate for resistance flow as a consequence of the radius. So flow is going to be proportional to radius to the fourth power. So if you were to do the math, let's actually go to a math question here. I'm going to fast forward a little bit. Over here. All right, give me 1 second. Help a little bit if you saw an equation. So let's do this equation real quick here. If you had one vessel, let's just say it was 1 centimeter in diameter, or 2 centimeters. Let's do 2 centimeters. So 2 centimeters, and then you double the radius to 4 centimeters. How much greater would the flow be, assuming that flow is equivalent to radius to the fourth power? So let's do this question real quick. You guys can crack out your calculators and do the math. So calculate 2 and then to the fourth power, and then see what 4 to the fourth power looks like. So what's 2 to the fourth power? 16. What's 4 to the fourth power? 256. So how would you calculate the difference? How would you calculate the difference? Huh? Subtract? No, you wouldn't subtract. You would divide, yeah. So you would divide 256 divided by 16. What do you get? 16, exactly. So anytime you double the radius of the vessel, you're going to be increasing the flow through that vessel 16-fold. So it's a pretty intense or marked difference as you increase the radius of the vessel. So let's go back. All right. And then for your arterioles are going to have a really huge impact in overall vasoconstriction in your body to control vessel radius and diameter. And arterioles can actually constrict to 1/3 of what their actual normal relaxed state would be. So you get a pretty significant change through your arterioles in general. So this is viscosity. In terms of blood compared to water, blood is going to be 4 times as viscous as water. So it's much, much more thicker. Anemia is going to have an impact on viscosity. Hypoproteinemia is also going to have an impact on viscosity. if you have like fewer proteins, for instance, like albumin in your blood is going to be less viscous. And if you get, on the other hand, polycythemia, you're going to get increased levels of viscosity. Polycythemia just means that your body is producing way too many red blood cells. So that's just going to increase your hematocrit level. And then dehydration, of course, can also increase your hematocrit just because plasma is going to be mostly made up of water. So let's talk a little bit about turbulence. Turbulence, generally speaking, is going to be due to arthrosclerotic plaques, or you can actually create a false state of turbulence when you're taking a patient's blood pressure. Now, has anybody in here ever used a sphygmomanometer before, or taken a patient's blood pressure? You have? Cool. So what do you do when you take a patient's blood pressure? Yeah? So first you put the blood pressure cuff on the arm, right? You can take this in different areas. You can take blood pressures in different areas, but generally speaking, you're going to take blood pressure from a patient's arm, right? So then you pump up the sphygmomanometer, which is the blood pressure cuff, right? And then you're going to constrict one of the major vessels in there. It's going to be the brachial artery, okay? So you're going to constrict the brachial artery completely. So that means no blood is going to be passing through the rest of the vessels into your arm. Then what you do is you put a stethoscope, right? Did you use the stethoscope when you took the blood pressure? You didn't use the stethoscope? Oh, okay. So you can actually just do a pulse as well. You can actually palpate the patient's radial pulse. You're only going to get systolic pressure from that. You're not going to get diastolic pressure. But it's one way if you don't have a stethoscope handy. So you can see what their, like the higher end of their blood pressure is. So if you constrict that brachial artery and then you're listening, as you loosen the blood pressure cuff, you're going to allow blood to slowly begin moving into that vessel. And then what's going to happen is you're going to actually hear the sound of the blood passing through that vessel. As you constrict the brachial artery and you let blood slowly come through, you're going to interrupt the laminar flow through that vessel. And then when you hear that sound, it's called a Kertkopf sound. So that very first sound you hear as the blood is whooshing through the vessel, that's called a Kertkopf sound. And so that first time you hear the sound, that's going to be corresponding with your systolic pressure. And then as the sound dissipates, when you stop hearing that sound, that's going to be your diastolic pressure. Generally speaking, 120 over 80. We're going to talk about that a little bit later in this chapter. But that's one way you can artificially create this type of sound disturbance within the vessel. Other ways that can happen is through arthrosclerosis. So as a patient starts developing arthrosclerotic plaques, that's going to interfere with laminar flow, and they're going to start getting turbulence. And if you auscultate, you can auscultate different regions. You can listen to the person's carotid arteries, and if they have arthrosclerosis, you'll be able to hear the sound of a bruit. You can also hear for renal artery constrictions from arthrosclerosis. And when you use a stethoscope for bruits, you're going to use the bell of the stethoscope instead of the diaphragm. So let me show you a little video of what that looks like. What's going on here? Hold on a second. Let me see what's going on with the volume. Volume is muted. Let's unmute that.
Well, other than being a funny sounding word that seriously sounds like a drink you would get at Starbucks, it's a noisy blowing sound found within a vascular structure like an artery due to the turbulence of blood flow. Now, the reason that these occur is because this artery could be narrow, meaning it's stenotic, so as that blood is rushing through there, it's making that blowing noise. Or there could be a partial obstruction, like through a fatty plaque. And here's an example of what one could sound like. And the reason you want to be familiar with these bruits as a nurse is because we assess for those. Like during an abdominal assessment, we listen to the aorta, the renal artery, and so forth. But we also listen to the carotid artery. So if you hear a bruit in the carotid artery, you want to report it because it could be a warning sign of a stroke. So let's talk about bruits. What are they? Well, other than being a funny sounding word that seriously sounds like...
All right. Get the idea of that. So you can check to see if the patient has any sort of arthrosclerotic plaques in any vessel by trying to listen for the presence of a bruit. In terms of calculation for flow, you can use, well, I wouldn't use this for this class. This is just a way for you to conceptualize how to calculate flow. But Poisson's law, flow rate's going to be equivalent or equivalent to the change in pressure, also the change in the radius of the vessel, and then it's going to be inversely proportional to viscosity. So in other words, if you increase the viscosity of the patient's blood, you're going to reduce the flow. Okay, so that would be labeled as N. So that would be blood viscosity. The greater the viscosity, the lower the flow. In terms of vessel length, same thing. The greater the length of the vessel, the less the amount of blood flow you're going to get through that vessel. On the other hand, if you increase the radius of the vessel, then you're going to increase the overall flow of the blood through that vessel. Let's move on. Cool. So let's do a little quick calculation here. So which one of these vessels is going to have the fastest amount of flow? Anyone want to take a guess? A, B, or C? Who thinks A? Who thinks B? Who's thinking C? Excellent. So C is the right answer. So in A, the change in pressure, the delta P, is only 40 millimeters of mercury. They're all going to have the same length and the same resistance. So that's one thing to keep in mind. But the change in pressure is going to be what determines the actual flow. So the second vessel here, 90 millimeters of mercury, where you start, and then it's going to end at 10 millimeters of mercury. The delta P is going to be 80. Versus the final vessel number 3, 180 millimeters of mercury where it starts, 100 at the end, that's going to be a delta P of 80. So vessel B and C are going to have equal amount of flow going through each of those. Okay. All right, what about this patient? So we have a 30-year-old male with fatigue, dizziness, weakness, headaches, etc. You order the CBC, and you notice that the patient's hemoglobin level is markedly elevated. So generally, it's going to be between 14 to 18. This patient has 21 as their hemoglobin. The hematocrit is really high, 63%. So you can diagnose this patient with polycythemia, which increases the amount of red blood cells that are going to be produced. So if the patient has a greater number of red blood cells, what's going to happen to their viscosity? Viscosity goes up, right? What about flow rate? It's going to go down. Excellent. And so because of a highly viscous blood from polycythemia, what kind of things could happen to this patient? What are some of the risk factors for having highly viscous blood? Anything. Take a guess. Huh? What do you think would happen if your blood is too thick to perfuse different vessels in your body? Did you say lower blood pressure? Not quite what I was thinking. Fatigue, yeah, kind of like what this guy's got. But yeah, sure, fatigue definitely. But like stroke, that's going to be one of the major concerns of having really thick, viscous blood. Stroke, ischemic events, right? So you get occlusions and thrombosis of different vessels. You can get like coronary artery disease as a consequence. So those are all going to be risk factors for having polycythemia and fatigue too. All right, moving on. So we already did that problem. Let's move forward. All right, let's talk about blood pressure. So generally speaking, when we talk about different types of pressure, we can discuss blood pressure, which is mostly what we're reporting. It's one of our 4 vital signs, one of 5 if you throw in pain. Some people consider pain to be a 5th vital sign. but it's going to be one of your 4 major vital signs. You can also look at capillary hydrostatic pressure. This is especially going to be relevant for lymphatics when we talk about lymphatics next week. So venous pressure, that's just going to be the pressure in your venous system. We don't really report venous pressure so much in a clinical setting. It's not super relevant. Blood pressure, you're going to have 2 major readings. You're going to have systolic versus diastolic pressure. Generally speaking, normal blood pressure is going to be below 120/80. And then if you have 90/60, that's also going to be on the low side of normal. Some people run even lower than that, and generally speaking, not great. You might want to start considering treating them with certain types of drugs that might help to increase their blood pressure. But then 120/80, that's going to be your normal read. Systolic pressure, that's going to be, as your ventricles contract, that's going to be the greatest amount of pressure that you're going to read from your systolic pressure. And then if you guys remember from the last lecture that we had, you have this dicrotic notch. That's going to be associated with the aortic valve's closing, right? Because of the elasticity of the valve, then you're going to see that kind of fluctuation in the pressure with the closing of that valve. And then during diastole, that's going to be the minimum amount of pressure in your arterial system. And generally speaking, it's going to be around 80 or so. Now, if you start getting blood pressure readings beyond that, you start getting into the realm of hypertension. Now, if you have a systolic pressure that's between 120 to 129/130, that's going to be increased blood pressure. It's going to be like kind of pre-hypertensive. And once you get into the 130s for the systolic pressure, that's when you actually start getting into actual true hypertension. And there's going to be a couple different stages. Previously, we used to call these pre-hypertensive, but now they call it stage 1 hypertension. So stage 1 hypertension is 130/80. So note that diastolic pressure is still 80. 80 is considered normal. What you're looking at is the systolic pressure here. Stage 2 hypertension, that's going to be when you get above 140/90. If you have a patient that comes in one day and you get a blood pressure read on them and they never really had any previous medical history, nothing significant, do you diagnose that patient with hypertension right away? You don't. At what point do you diagnose the patient with hypertension? Do you guys know? Huh? Yeah, how many times? Yeah, so 3 consecutive visits to the doctor where they have a reading that's going to be above 130 on their systolic. That's when you can actually diagnose the patient with hypertension. Do you start throwing drugs at them immediately? Do you want to give them beta blockers or ACE inhibitors? No. What do you do instead? You slowly what? No, not quite. You want to start trying to encourage lifestyle modifications. Generally speaking, you tell them to, exercise more. You tell them to moderate their diet. You tell them to reduce their sodium intake. Those are all going to be lifestyle modifications. You don't necessarily want to go straight to like beta blockers and drugs, right? You want to try to see if you can do a non-pharmacological approach first. And then if they can't control their blood pressure over time, then you can start giving them things like beta blockers, etc. It depends on how high it was. If it's really high, if their systolic was like 160 or something, I would probably start considering medication. Yeah, if it's like slightly above normal, right? If it's in that like stage 1 hypertension phase, then you would want to consider more of those lifestyle modifications. But yeah, you're right. If it's really, really high, then you're worried about hypertensive emergency or hypertensive urgency. Those are like critical stages of hypertension. I'll talk to you guys about that in a second here. I'll just show you this chart right here. So back in the day, we used to refer to elevated BP in stage 1. Those used to be considered pre-hypertensive. Back when I was in med school and I was doing my clinicals, that's what it used to be called, pre-hypertensive. Nowadays, that's changed. So stage 1, that's 130, 130 systolic. Diastolic, over 80. Stage 2, over 140. But yeah, if you start getting into like near the 180s, you absolutely need to treat that with medication. You want to try to bring that blood pressure down, because at that point, you can run the risk of getting CVA, cerebral vascular accidents. You can get ischemia, ischemic strokes, things like that. So huge concern when you're getting into this hypertensive crisis range. So let's go back into this. This is taking the blood pressure. We kind of went through it step by step, but you put the cuff on, you pump the cuff up. You want to go probably around like 160, 180 or so, and then you slowly start releasing the pressure in that cuff. Once you start hearing that sound of the turbulence, that's going to be called Korotkoff sounds, okay? That's what this guy over here is, Korotkoff. And Korotkoff sounds, that's going to be your systolic pressure once you start hearing that sound. And then when you stop hearing that sound, that's going to be in accordance with their diastolic pressure, usually around 80 or so. In terms of hypertension, hypertension is really, really common. Lots of people suffer from hypertension. So something that you're going to see every single day. There are going to be certain risk factors. So increased age is going to be a risk factor. African Americans tend to have more hypertension. Patients with diabetes are going to have greater rates of hypertension. And the biggest thing that we're concerned with is atherosclerosis, right? So atherosclerosis is where you have so much damage to those, the endothelial layer of your vessels, that eventually you start developing plaques as a result. A lot of that's going to be a consequence of just microvascular damage that's going to increase macrophages. Eventually those macrophages come colonizing the area and they become foam cells, and those foam cells over time are what turn into atherosclerotic plaques. Other risk factors, so stress, anxiety, that's going to be risk factors because of sympathetic activation. High sodium diet is going to be another risk factor. The more sodium you consume, the higher your blood pressure. Any sort of renal disorders can result in hypertension as well. And we're going to talk about the renin-angiotensin-aldosterone system more than likely on Thursday. So we'll talk about how the kidneys come into play in regulating your vasodilation and other aspects of your blood pressure. If you have hypertensive urgency or emergency or crisis, this is a really concerning symptom, is blurred vision. Epistaxis is another really concerning symptom. If you have a patient with like a headache, blurred vision, they start getting a nosebleed, you definitely want to make sure that you medicate that patient to bring their blood pressure down, because that patient is a really high risk for stroke. Other concerns, aneurysms. So an aneurysm basically is just an outpouching of your blood vessels. There's different types of aneurysms. For instance, in the circle of Willis, which you'll find in your brain, that's going to be a very common place where you can see what we call berry aneurysms. And there's different types of berry aneurysms. The aneurysm in and of itself is not the concern. It's if the blood pressure goes high enough to actually rupture the aneurysm. Those aneurysms are going to be a huge risk factor for a hemorrhagic stroke. So these are the different types. You can have saccular, you can have fusiform aneurysms. I'm not going to test you on the different types, but just know that when you hear the term aneurysm, that's what we're talking about. It's basically like an outpouching of the vessel. So stroke, vision loss is also a huge concern. Patients with diabetes as well as hypertension are going to have a higher rate of blindness, retinopathy as a consequence. A lot of your patients, if any of you guys go into like dialysis units or places like that, a lot of those patients are either diabetic or they had long-standing uncontrolled hypertension. Once they get to like stage 4 renal failure, then they have to actually start going into dialysis 3 times a week, 4 hours per session. So it's not a good situation to be in. In terms of testing, obviously you want to take their blood pressure, find out where they're at, and then you also want to try to rule out any sort of underlying causes of the hypertension. There could be a few, some of which could involve like medication. Certain types of drugs could induce hypertension. Certain conditions that can induce hypertension as well, aside from diabetes. So these are some other calculations for you to conceptualize how we test for pulse pressure and mean arterial pressure. Pulse pressure is basically going to be the difference between your systolic and diastolic pressure. So pulse pressure, you take your systolic pressure and you subtract your diastolic pressure. So 120 over 80, pulse pressure will be 40. Now your mean arterial pressure, that's going to be the average amount of pressure throughout your vessels. And mean arterial pressure can be calculated by taking the diastolic pressure, and then you have to add 1/3 of the pulse pressure. And that's going to be your mean arterial pressure. So if you had a diastolic pressure of 80 and you had a pulse pressure of 40, 1/3 of 40, and add that to 80, and that would be 93 millimeters of mercury. That would be the average pressure within your arteries. Now, I like this chart over here. This is from your textbook. This shows the overall pressure in different regions in your circulatory system. So in your ventricle, you have huge fluctuations of pressure, all the way from 120, which would be equivalent to the systolic pressure, all the way down to 0 during diastole. Once you start getting to the arteries, for instance, like your aorta, that's when you start seeing, that's where you're able to measure the actual systolic and diastolic pressure. So take, for instance, if you're doing your brachial artery, your average systolic would be 120 over 80. As you start getting further and further away from the heart, that's when you start seeing that mean arterial pressure over time dropping down until you get to the large veins. So let's talk a little bit about elasticity in those larger arteries. Larger arteries are going to have a lot of elastic tissues that allows for greater recoil. So as the ventricles pump and you're getting blood entering into the aorta, that aorta, to be able to accommodate all the blood, is going to actually be able to stretch quite a bit. So there's going to be a lot of elastic tissues within those vessels to accommodate for that stretch. Then as you have, then during ventricular relaxation in diastole, in order to help push that blood further, the elasticity of the aorta is actually going to be able to help continue pushing the blood further down the circulatory system. So we already talked about mean arterial pressure. Move on. So let's talk about how we control the direction of, well, not the direction, but how we delegate blood to different tissues. Now, arterioles are going to be the most important vessels that help to regulate blood pressure. Arterioles are going to have a lot of smooth muscle that helps to vasoconstrict or vasodilate, and arterioles are going to be basically the entry point into your capillary beds. So it's going to be able to help shunt blood into different areas based on the demand of those tissues. On. We already talked about flow. Let's see, let's move on here. All right, let's just conceptualize this with images. So let's talk about venous return as well as total peripheral resistance. So last week, when we talked about cardiac output, we spoke in terms of preload versus afterload. But when it comes to vessels, we can still use the same kind of terminology and concepts so that we can figure out how much blood is coming to the heart and how much pressure the heart is going to be pumping up against. So preload is basically going to be equivalent to the amount of venous return you have. Versus afterload, think about afterload as being total peripheral resistance. So if you calculate for cardiac output, remember that's the amount of blood that's being pumped throughout your body within 1 minute. So that's going to be your heart rate multiplied by the actual stroke volume, the amount of blood that's able to get ejected out of your ventricles. Then when we talk about mean arterial pressure, we can think of it in terms of cardiac output multiplied by the total peripheral resistance. In other words, mean arterial pressure is going to be the pressure that your heart is going to be pumping up against, or afterload. So let's do these problems here. So if you had decreased venous return, if you have decreased preload, you have decreased end diastolic volume, decreased end systolic volume. Is your cardiac output increased or decreased? You can use your fingers if you want. Decreased. Good. So cardiac output is going to be decreased as you have decreased venous return. If you have decreased cardiac output and multiply that by the total peripheral resistance, what's going to be your mean arterial pressure? Increased or decreased? It's going to be decreased. It's going to be reduced. So decreased cardiac output, you're going to actually have decreased mean arterial pressure because your heart's contracting, right? If your heart is contracting less blood over a given minute, then you're going to have reduced mean arterial pressure. What about preload? If you increase the amount of preload, what's going to happen to cardiac output? You're going to have increased cardiac output. You're going to have increased total, mean arterial pressure because of when you multiply cardiac output by total peripheral resistance, that's going to increase your mean arterial pressure. If you have increased venous return, more blood is coming towards your heart. That's going to increase your preload, increase end diastolic volume and stroke volume. What's going to happen to cardiac output? Increase mean arterial pressure also is going to increase. So that's going to be from the venous side. What about the arterial side? So this is going to be afterload. So if you have reduced afterload, what's that going to do to your total peripheral resistance? Increase or decrease? It's going to be decreased, right? If you have more to push against, you're going to have an increase in that total peripheral resistance. So with lower total peripheral resistance, you're going to have what? Decreased mean arterial pressure, right? And then if you have vasoconstriction, that's going to be one of the major ways that your vessels increase your, it's going to increase your afterload, which, what does that do to your total peripheral resistance? Increase or decrease? Increase, right? And then cardiac output multiplied by increased total peripheral resistance increases the overall mean arterial pressure. So what if you have increased sympathetic activity, right? You start releasing catecholamines from your adrenal medulla. You're getting chased by a lion. You have norepinephrine, epinephrine circulating in your throughout your body. What is that going to do to your heart rate? It's going to increase, right? Excellent. So you're going to have increased heart rate, and you're going to have increased contractility, which means what to your cardiac output? Increased cardiac output. Awesome. So it's pretty straightforward. Just use these different terms to help conceptualize the amount of blood that's actually flowing. If flow increases because of dilation versus vasoconstriction, which would increase the pressure, that would decrease the total amount of flow rate. So let's do a couple questions, and then we can try to get into capillaries after this. So let's go ahead and do a few questions that I put together for you guys. All right, I think there's a couple more. I think I counted about 53. So is anybody having a hard time logging in? All right, if you're having a hard time logging in, just give your name to Sabudia and we'll make sure you get credit for today. Excellent. Good. So yeah, veins are going to be what you find the least amount of pressure. Pretty straightforward. All right. Excellent. So largest vessels in your arterial system, those are going to have the greatest amount of recoil. So the aorta is going to have way more recoil than any of your vessels in your venous system. Next. All right. Predominance of oxygenated blood can be found in the pulmonary vein. So yeah, that's one of the major differences between the pulmonary vein and the pulmonary artery. Pulmonary artery is going to be carrying deoxygenated blood. Right? Pulmonary vein is going to be oxygenated blood. Make sure you don't confuse those two. It's important to be able to differentiate between the vein and the blood because arteries, if you recall, bring blood away from the heart, veins back towards the heart. It's not always determined by oxygenation. Excellent. The tunica media, that's where you find a much thicker, smooth muscle layer than you would in veins. So the tunica media is going to be the major difference between the veins and the vessels in terms of the different layers. And then tunica adventitia, that's the same thing as the tunica externa. Think of them as being one and the same. Bless you. All right. So flow increases with decreased resistance, right? So if you have, for instance, less viscous blood, if you're well hydrated, you've been drinking a lot of water, you've increased your blood volume, your viscosity in the blood is going to be reduced. That would help to increase the actual blood flow. Blood flow would decrease with resistance if you increase resistance, and it would the delta P, the change in pressure, that's going to impact the amount of blood flow. So if you have a greater delta P, that's going to increase blood flow, and then viscosity, that decreases your blood flow. Vascular resistance can be increased with vasoconstriction. Excellent. Pretty straightforward. I think I'm going a little bit too easy on you guys. Excellent. So yeah, Brewy, you're going to have disturbances in that laminar flow. If you have any sort of turbulence, that's going to result in uh, uh, extra sounds that don't belong there, unless you're taking a patient's blood pressure, in which case that'd be intentional. All right. So in terms of radius, what is flow directly proportional to? Huh? What's the little equation? Huh? Radius. R to the power of what? 4. Right, yeah, exactly. R to the power of 4. So as you double the radius, that's going to increase the flow rate by 16. Okay, so it's going to be a 16-fold increase in the overall flow through the vessel. So in other words, every time you double the radius of a vessel, it's going to dramatically increase the amount of flow through that vessel. All right, and last one. Awesome. Elevated blood pressure. Once you get to 130 over 80 and above, that's going to be considered stage 1 hypertension. And if you get 140 over 90 and above, that's going to be stage 2 hypertension. Good. Nobody said a hypertensive crisis. You have to be at least over 180 systolic or 120 diastolic for that. This person would not be considered normal blood pressure. You would definitely want to tell them to do a little bit of like lifestyle modification. What else could result in a increased blood pressure, like that's like slightly elevated? What's something else that could happen? Yeah, they could have been active. So when you take a patient's blood pressure, generally you tell them don't eat anything, don't smoke anything, don't drink any coffee, right? And then how long do you want them to remain rested before you actually take their blood pressure? 10 minutes, 15 minutes, usually about 15 minutes is a good rule of thumb. What else can happen though? What else could elevate the patient's blood pressure? Stress. Could a person get stressed when they go to see a doctor or a nurse? What do they call that? Huh? Anxiety. Yeah, a white coat syndrome. White coat syndrome is actually a real thing. Sometimes people just absolutely hate going to see a doctor, and just by going to see a doctor, their stress levels are going to be elevated, and that's going to actually have an impact on their blood pressure. So that's one thing to keep in mind. So interesting stuff. All right, let's go a little bit further into chapter 20. Any questions so far? No questions? Congratulations, Melissa. All right. So mean arterial pressure. What are the things that can elevate mean arterial pressure as a whole? So on the left here, heart rate. Heart rate is going to be dictated by several different factors. Sympathetic activation, for instance, fight and flight. Fight and flight will release norepinephrine, epinephrine. Also, you can get T3, T4. So thyroid hormone can actually have an effect on your overall heart rate. So if you have a patient that's hyperthyroidism for whatever reason, they might also get increased heart rate, which would increase cardiac output, increase their mean arterial pressure. Beta 1 receptors. You have several different receptors in your heart, but the most predominant ones are going to be beta 1 receptors and muscarinic receptors. Beta receptors, beta 1 for the heart, beta 2 for the lungs. Muscarinic receptors are also going to be in the heart too. But if you do sympathetic activation of your heart, it's generally going to be beta 1 receptors. That's why if you take a beta blocker, like metoprolol, labetalol, atenolol, any of those LOL drugs, those are going to block your beta 1 receptors, thereby reducing heart rate and reducing cardiac output. Body temperature can also increase your heart rate as well. In terms of stroke volume, remember, if you have more blood coming to your heart, that increases end diastolic volume. That's going to also increase your stroke volume as well, aka the more preload, the more venous return, you get increased stroke volume. Contractility, if you activate those beta 1 receptors. And then we're going to talk about this later, but the angiotensin aldosterone pathway, that's going to also increase stroke volume as well, along with antidiuretic hormone, right? If you prevent diuresis, if you prevent urination with the release of ADH, then you're going to increase your blood volume. Increasing your blood volume is also going to increase your stroke volume. And then in terms of peripheral resistance, so the peripheral resistance, that's going to be associated with afterload. That's going to be associated with like vasoconstriction. Can also be affected by increased viscosity of the blood. That also increases your total peripheral resistance. That can also increase your overall mean arterial pressure. This is a really good summary that talks about all those different variables. So make sure to keep this chart in mind moving forward. And then here's just like some sample questions. I'm not going to go through all these. Just go ahead and go through them on your own, just so you can like familiarize yourself with the different elements and factors that play into your mean arterial pressure. Here's another one as well. So do that on your own. If you have any questions, just shoot me a message and let me know, or come by and visit me in my office. So let's talk a little bit about capillaries. Let's go for like another 5 minutes or so, and then we'll call it a day. In your capillary beds, you can actually get neovascularization. This is pathological. If you get corneal neovascularization, generally you need to try to treat that patient. It can affect their vision. Rosacea. Rosacea is another common thing. It happens a lot to patients of Eastern European, Scandinavian ancestry. If you look up rosacea or telangiectasia, generally it's going to be associated with sun exposure, but you can also have other risk factors that play into that too, like alcoholism, for instance, can actually result in rosacea. Telangiectasia is also referred to as spider veins. Remember I showed you that video of telangiectasia being treated with sclerotherapy. So you can actually treat that with different types of procedures. So let's talk about different types of capillaries. There's 3 major types of capillaries. The most abundant of all of them are going to be continuous capillaries. They're going to be the most common throughout your body. They're going to be found in skeletal muscle. They're also going to be found in your brain. They're going to be found in your heart. And then you have fenestrated capillaries. When you hear the word fenestrated, and if tu parles le français, fenestre is a window. I think it's fenestra, something like that. But fenestrated, think windows, think openings. So if you have openings, that means that you're going to be able to increase the amount of things that can basically travel across the capillary bed. So you're going to find it in places where you have like filtration, for instance. Kidneys, you're going to have fenestrated capillaries. Your GI tract and your intestines, you're going to have fenestrated capillaries. Endocrine glands, where you're secreting different types of hormones, you're going to see fenestrated capillaries. And then sinusoidal capillaries, those are going to be a lot larger. They have bigger openings. You're going to find those in areas that are like highly vascularized, like your liver, right? You have lots of things filtering through your liver, especially for like metabolic processes, right? Like cytochrome P450 enzymes are breaking down things like drugs, alcohol, toxins in the environment. So you need to have a lot of openings in those vessels so you can allow for greater vascular permeability. Spleen, similar thing. The spleen is going to have lymphatic properties, and it's also going to be heavily implicated in sequestering damaged red blood cells. So the spleen is going to have a greater degree of sinusoidal capillaries. Bone marrow, right? That's where you have erythropoiesis, hematopoiesis. That's all going to be requiring a greater amount of openings in those capillary beds to allow things to cross over the layers. So in your capillary beds, if you remember from that chart that I showed earlier, blood is going to be flowing very slowly through your capillary beds. You have a much wider surface area of capillaries compared to any of the other vessels in your body, much more so than arteries or veins. But because of how narrow they are, remember, the smaller the radius of the vessel, the slower the flow is going to be through that vessel. And that's going to be really important because you want the blood to be able to travel slow enough so you can get maximum amount of exchange of both gases, right? So carbon dioxide, as well as oxygen, as well as like the transfer of wastes, nutrients, etc. So you want those the blood to flow much slower through those vessels. So in other words, those vessels are going to have a large surface area if you were to take all of them into consideration throughout the whole body. But the narrow radius is going to make them very slow. So you're going to have maximized exchange of things like nutrients as well as gases. Now, in terms of the thickness of the vessel, capillaries are going to be very, very thin. So because of being thin, you're going to get a lot of ability for diffusion. Just, for instance, simple gas diffusion. Anything that's lipid soluble can just pass right through the endothelial layer. And then you might have little tiny openings as well that can allow for passage of things like solutes, like ions, sodium, potassium, etc. Now, in terms of diffusion, or in terms of movement of materials, there's like two major ways that materials move. Passive diffusion, so gas exchange. When your erythrocytes are moving through the capillary beds, they're unloading oxygen and they're bringing on carbon dioxide. That is just simple gas diffusion. That's going to be the major way that you have substances moving in and out of the capillaries. You can also have bulk flow, and that's going to be associated with movement of materials into the ECF, the extracellular fluid. So that's going to change extracellular fluid volume. We're definitely going to get into more of that once we get into lymphatic system as well. Now, in terms of things that can easily move across the membranes, lipid-soluble substances. Anything that's lipid-soluble can go diffused right through the endothelial layer. It doesn't need any sort of like channels. It doesn't need any special openings. It can just go right across. So carbon dioxide, oxygen, steroid hormones. Remember, steroid hormones are going to be lipid-soluble. They can go directly into the cell. They don't need to have any sort of special like second messenger system or anything like that. And then water-soluble substances, those are going to mostly go through water-filled pores. So I'm going to show you an image of what that looks like in a second. But things like ions, right? Ions are going to be charged particles. Usually they need, for instance, like sodium-potassium ports, ATPase, sodium-potassium transport pumps, things like that. So ions are going to be important. Are only going to be able to move through these water-soluble type water pores. Glucose is also going to have to move through these types of pores. Amino acids, and then plasma proteins. This is really going to be important when we get into hydrostatic pressure versus oncotic pressure. So albumin, really important in terms of maintaining hydrostatic pressure. Generally, albumin is going to stay within the blood vessel. It's not going to escape through the blood vessel. It's not going to be able to move past those capillary beds. And albumin is going to be heavily implicated in maintaining the ability for water to leave the interstitial space back into the vascular system. So here's just an image of what that looks like. You have plasma proteins are not going to be able to leave the lumen of the vessel. They're going to stay within the vessel. You might have different types of proteins that could potentially cross if they have exchange proteins. In terms of lipid-soluble substances, they can just cross directly over the phospholipid bilayer without any problem. So carbon dioxide, oxygen, that's going to be an example of that. And then for solutes, water-soluble substances, they require pores for them to be able to move through. So anything like sodium, potassium, glucose, amino acids, those are all going to require pores. So I think let's call it a day over here. We'll continue on Thursday on diffusion and osmosis. And have a happy Valentine's Day, everyone.